We have lots of physicians that do also get like an MPH or get an MSc in EPI and apply a lot of those frameworks and approaches to the people that they look after in a clinical setting. It's quite comprehensive and unique approach in PHPM is that you're constantly thinking about population and community level approaches and frameworks, as opposed to someone who is a physician that works at individual patient level medicine and maybe only has the opportunity like one day of a week.
This is the Public Health Insight Podcast.
My name is Will, your host for this episode, and I am here with co-hosts Ben, Linda, and a special guest.
Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
Typically, when people hear the term medical doctors, they often think of family physicians, pediatricians, surgeons, or something along those lines. However, there is one medical specialty that is often overlooked. The ongoing COVID-19 pandemic has brought public health and preventative medicine to the forefront of public discussions. And on this episode of the Public Health Insight Podcast, we'll be chatting with a public health and preventative medicine resident about their journey into this specialty, their experiences, and lessons learned so far. Dr. Yipeng Ge is a Chinese-Canadian first-generation immigrant and a humble and grateful guest of this land. He grew up in Waterloo, Ontario, and completed his undergraduate studies at McMaster University in Health Sciences with a specialization in global health. He received his MD from the University of Ottawa Faculty of Medicine and is currently a resident physician in public health and preventative medicine in Ottawa, Ontario. He is also a member of the Board of Directors for the Canadian Public Health Association and currently serves on the Board of Directors for the Canadian Society for International Health and Canadian Medical Foundation. Yipeng is passionate and interested in tackling health and social inequities through addressing the social and broader determinants of health. Much of his academic and medical career has been guided by these values. Yipeng has worked for various global health organizations, including the World Health Organization headquarters in Geneva, Switzerland, and the Population Health Research Institute in Hamilton, Ontario. In 2020, Yipeng was Canada's official youth delegate to the 73rd World Health Assembly and the 58th Pan American Health Organization Directing Council. It is my pleasure to welcome my friend and colleague, Yipeng, to the Public Health Insight Podcast.
Welcome.
Thank you so much for the invitation. I'm really excited to be here.
To begin, we'd like to ask a bit about your role as a public health and preventative medicine specialist. Speaking as a current resident, I think it'd be useful to talk a bit about the specialty because I've found that, in all honesty, even before I did my MPH or even got into public health, I didn't really know that this was a real thing, or not a real thing, but like that this was a specialty. Like when I thought about medicine, I thought, okay, you have your family physicians, your pediatricians, your surgeons, and like that's it. So maybe like kind of if you can just give us a quick overview of what is public health and preventative medicine.
Yeah, for sure. I think that's a good place to start because I'm coming just off of a 3-month redeployment rotation with Ottawa Public Health. And normally I wouldn't have had this experience in working in local public health as a junior resident physician. Normally these rotations take place in the latter years of residency training in public health and preventive medicine. But I think for everyone, I think it's helpful and thinking about when I was a medical student and also even before that, the field of public health and preventive medicine is a confusing one to understand and still something that actively now, a year into a pandemic, still has lots of people scratching their heads with regards to what the field of public health and preventive medicine is. So I think it's a good place to start for a lot of good reasons. as we know, for those people that end up going into medical school and training to become a physician, medical school is typically 3 to 4 years across the country in Canada. And after that, you do your residency training, your additional training to become any sort of specialist, including a family medicine specialist. And that additional training can be anywhere between 2 to sometimes 6 or even plus years to be able to practice independently without direct supervision from another supervising physician. And one of those fields of training is public health and preventive medicine. And what I think is a nice way to conceptualize things, and I realize it's always a bit of a challenge to in terms of kind of conceptualizing and understanding the role of a public health physician, because oftentimes and many times when we think about the role of a physician, we see a doctor in a hospital or a clinic talking to an individual patient, providing care, figuring out what the diagnosis is, what the treatment is, prescribing a medication or prescribing fluids or whatever therapy that individual might need, or counseling, and then figuring out what plans might we need to involve other people, other health professionals, to be able to support this individual around oftentimes what is disease and illness in that particular situation in a clinic or hospital. But I think taking a step outside of what we know to be a disease and illness-based system, what we call the healthcare system, we can think more broadly of what we think of is a health system in its broadest terms. And I think your listeners and yourselves probably know very, very well that public health kind of touches on all those things that affect someone's health and well-being at a community and public level. And public health and preventive medicine specialists who are trained clinically, but also have this lens of thinking about the health and well-being of an entire community or an entire population, and what interventions or programs or policies might best fit at a population or community level to be able to influence and assist in promoting and protecting the health and well-being of our patients, which is just coming off of a rotation with Ottawa Public Health. Our patient or patients is the city of Ottawa and its citizens, which is like thinking about interventions for an entire community of people, which is a very different mindset than thinking about the patient or the patient and their loved ones in front of you in a clinic or in a hospital setting. And I think I hope that's a helpful start to what is a whole stream of professional thinking and identity around how best to do those things, in a pandemic and outside of a pandemic, recognizing that so much of the groundwork for what we know to be public health essential functions and competencies also came out of the 2003 SARS report recommendations, and so it's a constantly, I think, evolving idea of at a systems level and at multiple levels, how do we work to achieve health and well-being for all?
Yeah, no, that's a very comprehensive introduction, Yipeng. And I think something that, from what you said, that really resonated with me is the idea of, the patient in the sense of, in your case, was the city of Ottawa and its residents and its population, right? And I think, very much like public health, it's not just looking at an individual, but it sounds like it is very much at the population level. I'm just a bit curious then, other than the obvious distinction that to become a public health and preventative medicine specialist, you do need to go through your MD training and have, go through those schooling. Do you find that the PHPM experience differs from what you would learn in an MPH, or do you think it's a lot of the same takeaways or competencies?
So that's a great question, Will, and something that I still need to work through is getting my academic training in the public health, kind of like the formal academic training in public health and preventive medicine. So that'll come after I finish my family medicine clinical training. So I'd love to listen to what I have to say now and compare it to after I get my MPH or MSc in epidemiology or whatever I end up doing in 2 years. Mm-hmm. But my understanding is that getting those theoretical concepts, but also practical knowledge and skills that come with a master's degree relevant in the field of public health, such as an MPH or an MSc, or some people do a master's in public policy, or depending on what their career goals are in the field of public health and preventive medicine, is you're getting those skills and competencies to be able to put those things into action as a public health and preventive medicine specialist. And depending on the level of public health one ends up practicing in, some of those kind of areas of work might differ. So depending on if you're at a local or regional level, looking after like an entire city or a region of a particular province, or if you're working at a provincial, territorial level, federal level, national level, sometimes international level. And the things that you take out of those academic training, formal academic training courses and lectures, you'll be able to apply those things a bit differently based on kind of your scope of practice, essentially. But also recognizing that kind of the key essential functions of public health, like health promotion, health surveillance, disease and injury prevention, population health assessment, health promotion, and disaster and emergency response, which we're seeing a lot of these days with the COVID-19 pandemic. All those different core functions will apply a bit differently at all those levels. And depending on if you're more of a generalist, thinking if you're particularly working at a local level and you kind of have your mind or hand on a lot of different issues through all those different core functions, or you're more of a specialist in public health where you kind of focus in on infectious diseases and outbreak management, or you focus more on health promotion and how do we think about building healthier cities and communities through built infrastructure and things like that. The things that will draw on from those academic training years will be a bit different. The other thing I think, and I'm still, in my formal residency training years of trying to conceptualize what is the role of a public health professional that doesn't have that medical training compared to someone who is a public health and preventive medicine specialist who has that medical training, and how those roles differ a little bit is something that I'm still trying to get a better grasp of. One thing that has been kind of clearly evolving over the way that public health has been structured, at least in Canada, is that public health and preventive medicine specialists, often those that have the clinical training, find themselves in leadership roles in public health units across the country at multiple levels. And I think there has been lots of reasons for why that might be, but then I think it's a thing that we're seeing over and over again, reflected on how the future of public health might look, because I think there's lots of lessons that have come out of the pandemic in terms of the unique role that public health and preventive medicine specialists really share when it comes to how do we think about health and well-being and all of the various determinants of health, and some of the most broadest determinants of health affect people's health at a community level. And some of the lessons too around like mass vaccination campaigns and collaboration with primary care, and a lot of the integrations there, recognizing that even though the healthcare system is super disease and illness focused, some of there's a large workforce in the healthcare workforce that is primary care, and that think about prevention as well, and think about health promotion as well. And how do we integrate those things into an appointment when a patient does come in and see their family doctor about something, but you're able to chat and counsel about some of those prevention pieces. So I think it's quite interesting to think that public health and preventive medicine specialists often get dual training in family medicine, and so they're also family doctors, and have that direct kind of line and connection to patients as well. And I think that often lends for some really helpful contextualizing of some of the issues that we see often in public health.
That's a great point. I had a question, especially about your point about leadership and the whole upstream approaches and the downstream approaches as well. Is that one statistic that really stood out to me was the amount of PHMP residents per province in Canada. So Newfoundland and Labrador had two physicians in the entire province based off 2019 stats. The territories had none, and then Quebec had 210. So clearly there's a big difference in this. And then another statistic they had was, physicians per 100,000 people population. You had, again, Newfoundland with 0.4, you had Quebec with 2.5. So it's all hovering around these very small numbers. So I was wondering if you could comment to that in terms of how do we transition into more individuals gaining into these more upstream approaches, upstream leadership positions?
Yeah, I struggle with thinking why that might be too. Thanks for that question. I'd be interested to look further into those numbers, but it's not surprising to me to think about how we don't have a lot of public health and preventive medicine resident trainees across the country, and we don't have a lot of physicians across the country seeing as though the need for public health and preventive medicine specialists during this pandemic. Well, I've had a few interesting conversations with medical students that are interested in going into this field, and sharing some of the resources that others have shared to me. And one of those links was a link to open job postings for PHPM. I'll start saying PHPM instead of saying the entire public health and preventive medicine, just so we don't get a super long podcast just of me saying that word or that collection of words. But I think it was a reflection of how there is a shortage of PHPM specialists, and I think I don't know all of the pieces around what goes into health human resource planning across the country. This has been a hot topic for many years, and probably for since we've had physicians. Like, what is the right ratio of X type of physician to X community, and how do you also balance that with the number of all those things that influence the number of physicians that we have at the end of the day. So residency training locations and numbers, and then medical school seats and numbers across different distributions. And I think it's quite common sense that we need to make those decisions based off of community need, and how best can that be reflected in every step of the way, I think has always remained a bit of a challenge. In terms of how do you plan for PHPM specialists is interesting, because we know that communities are different across the country, and there have always been conversations about how to structure public health in a way that makes sense for a certain community, a certain group of peoples, or a certain geographic location. And you get into the weeds a little bit when thinking about some of those conversations, because it also means changing the existing structures at play, and that might mean people losing either power or privilege, or people losing their jobs, which is quite a challenging thing to talk through. But I think if we think back to what is the need, and how do we address that need in terms of what is the community's true need for any type of specialist, so that their health or disease or illness can be thought of for a physician. But then for a PHPM specialist, how do we identify that gap for community level thinking around health and well-being? And the other challenge too is where we are able to train PHPM specialists depends on having teachers, having people that practice that kind of medicine, public health medicine, so that we have enough training opportunities, enough mentorship, enough scholarly kind of guidance, so that we're able to produce really competent, strong PHPM specialists. And so one of the challenges that we know of is that, as far east, the farther east you go, and especially in the maritime provinces, there are no PHPM specialty programs, and I think there's some thinking now to kind of see how best to structure that. We in our PHPM program, we actually have 2 senior residents, Dr. Oster Zygmunt in Nova Scotia and Dr. Jen Lemesser in Newfoundland and Labrador, that are doing their final kind of senior leadership and other rotations in their home provinces, and perhaps building more capacity for PHPM specialists and PHPM thinkers to train with them out east. But when we don't have the capacity to have a comprehensive training program, it's a complex problem, because then perhaps it's a cycle of not having where a lot of good training and a lot of good mentorship and a lot of good teaching happens, thinking about how I think in particular lots of urban and dense settings really attract a lot of great potential, and thinking about all those things that are centralized perhaps in the GTA, and so it's almost like a reflection of the broader issues of almost like resource allocation perhaps. Where are the good education training programs, and why are they so centralized, and why can we not decentralize them a bit more and think about community need for education? But then that leads to practice. It leads to the practice that will eventually serve the population, the community that people are coming from and are in.
And then adding on to that point, sorry to keep hammering that one, but there was an interesting thing that you said where, back in the SARS era, that really sparked the creation of public health in Toronto and those infrastructures. Do you think with the current pandemic, or whatever you're noticing right now in your field, is that a catalyst for building more PHPM residency potential? And is that something where these numbers that we're seeing right now in 2019, do you think those are going to grow exponentially in the future?
Yeah, I think it's hard to know what the pandemic will, like the COVID-19 pandemic now, will do to the structure and the capacities for public health. A significant worry of mine that I think is shared with other colleagues is the burnout that has happened in the profession up to today, and what it means moving forward too. But I think if we take a step back from all of the challenges that public health continues to face with, responding to an ongoing crises, and some oftentimes multiple crises, thinking about other challenges that exist, such as housing, such as addictions and opioid use, and also the climate crises, which public health has a role in as well, in terms of how to mitigate and adapt to the climate crises. With all of that said, I think there will be lots of thought leaders in public health and probably in other spheres to think about what is the right balance of having a good workforce in public health to be able to respond, continuing to respond sustainably to all of these crises moving forwards, and knowing that there's lots of good journalistic reporting that has happened during the pandemic, and some of that journalistic reporting has cited the the challenges of the public health workforce and some of the previous thinking around restructuring and how public health like organizations or institutions should do their work, and what that kind of good consistency or makeup within that organization is, in terms of different public health professionals and public health physicians, and how do you have that balance of the thinkers and the doers and like the management and the strategy people, like and so I think all of that will come, and it has already been and is an ongoing thought because of how these structures continue to function in a crisis. I think back to March when I also worked a little bit as a fourth year med student, transitioning into the role of a public health resident physician at Ottawa Public Health, and things were just starting to be stood up in an incident management structure to be able to respond to a crisis. And those structures work well in an emergency for certain reasons, right? Like you're able to communicate really effectively with a lot of people, but is also very resource intensive. And I also think back to Dr. Teresa Tam, and I think it was the Canadian Public Health Association's conference last fall, and how she said, in this pandemic, she's had access to a whole suite of ministers to think about how do you collaborate to kind of put health and well-being at the top of the agenda in all these different ministerial files. And so it's interesting that the emergency structures that were put in place in terms of workflow has made these channels of communication open a lot easier. And it'll be interesting to see, as things calm down from an outbreak management perspective, will some of those channels close up? And should they close up? Or should we actually continue to talk about, I think I'm biased in thinking health and well-being is of the utmost priority for communities, but not everyone thinks that, or I think thinks about well-being and health in a different way. But when we think about putting health and well-being at the top of the agenda for our communities, I think if we structure our institutions around that, only good can come from it. And perhaps that means drawing from a lot of things that have happened over these past months in terms of how things were either have been able to get done in a really quick way to manage a COVID outbreak in a shelter system for people who don't have a home or are precariously housed. And how do you apply that thinking to just the homelessness crisis to begin with? How do we mobilize resources to get people properly housed? how do we apply that thinking and urgency to some of these other issues so we can quickly grab all of the important decision makers and partners and collaborators and community members so that decisions can be made quickly, because we know that there are so many concurrent crises going on.
Yeah, I wanted to talk a little bit about this distinction between primary care and public health. So Yipeng, you had mentioned, typically we think doctors in a white coat with one-to-one patient care versus a PHPM specialist, your patient is the population. And then Ben, you had mentioned too, in your discussion with Yipeng, how there's that shortage of PHPM specialists, and how do we address that issue? So I wanted to talk about how PHPM kind of merges public health and primary care together. And so I wonder if it wouldn't be more a better use of our resources to make this type of training mandatory for all medical students, all types of training, because I think that it's a huge gap we're noticing, right, in our primary care system. It's not uncommon to go to a family doctor and you're there for 3 minutes. It's one issue, you leave. So why does it take a PHPM specialist, who there's maybe only 2 in the Maritimes, to have this understanding of prevention and holistic wellness? Do you think this is something that should be incorporated more into medical training to have a more comprehensive response in our system to addressing these gaps?
Yeah, that's a great thought. I agree with a lot of what you said there in terms of how do we train all of our physicians, really, and doctors across the country to be able to have the thinking that is needed to be able to improve collective well-being and health. Mm-hmm. And lots of physicians do this already, and they work with individual patients, but they also think of how do I improve the care for this entire group of patients that I practice for, mm-hmm. Either through quality improvement work or through quality assurance work or through various research kind of processes to think, is there something that I'm missing here, or is there something that I'm doing that's really good here that I can apply mm-hmm. and share with others at a population or community level, and lots of that kind of work does take place, and we have lots of physicians that do also get an MPH or get an MSc in Epi and apply a lot of those frameworks and approaches to the people that they look after in a clinical setting. It's quite comprehensive and unique approach in PHPM is that you're constantly thinking about population and community level approaches and frameworks, as opposed to someone who is a physician that works at individual patient level medicine and maybe only has the opportunity one day of a week or a few days on the off chance that they get a break from individual clinical patient medicine. They start to think about, is there a research project here that I can apply some of these concepts of population and public health to the people that I'm looking after.
I think my comment was more so along the lines of how a more type of public health training could enhance a physician's one-on-one interactions with the patient. For example, if someone comes to a physician who is for example, they're overweight, and their recommendation, the treatment that they're given is, you need to incorporate more exercise, and that's just the conversation that's had. But there's no type of, consideration of what other social factors are impacting this person. But you, as someone with training as a PHPM resident, you may automatically think, what are the social determinants at play in this person's life? Mm-hmm. Whereas someone whose training is more focused on primary care and more clinical aspect may not necessarily think that. And so I totally understand too, your limited resources. You cannot always think about population when you're focused on a person. But when you look at a person, with that public health training, you may be more inclined to think, what else is impacting their situation?
Yeah, I couldn't agree more with that kind of thinking, especially for primary care physicians that see their patient and see certain issues present and represent. We always have to think down, why, the causes of the causes for why is the patient coming to you for this issue. Is is my intervention actually my recommended intervention that you come to agreement with the patient on, is it actually addressing the root cause? I think there's so much thought in this area around social medicine and a lot of great work in social pediatric medicine too, because we know there's so much great investment when you're able to give someone who's in the early years of their life and put them on a good trajectory, so that they end up having better, healthier outcomes and behaviors through the course of their life. And so it just compounds, the benefits to society, the benefits to community, the benefits to themselves and their loved ones. The challenges that I kind of think through when it comes to individual patient medicine is sometimes there are some good interventions that you can think of, are there social assistance things that you can put into place. Sometimes it means leaning on our colleagues in social work to be able to identify certain resources, or if it means doing a home visit because it's really challenging for this patient to actually make their way all the way to the clinic. And I've seen that done with some really amazing family physicians as well. But sometimes some of the key levers or to address the causes of the causes are not within the immediate reach of the physician providing individual patient medicine. And that, for me, speaking personally, that was one of the biggest factors for me to want to go into PHPM, because some of those levers are not readily accessible in clinical medicine, and sometimes they're even hard in PHPM. We have to rely and work with other collaborators and city partners, or depending on what level of public health you're working at, you work with various other stakeholders and partners to be able to think, okay, the cause of the causes here is poverty. The cause of the causes here is having stable, affordable housing. So how do we get that? How do we get that for our community? How do we get that for this group of people that have been, structurally less advantaged due to systemic inequities and injustices over time? And how do we change so many different things around policies and funding and leadership to be able to turn the tables around and move together forwards in a good way. To go back to one thing that you initially said around, are we training our physicians and medical students in a good way to be able to understand some of these concepts? I think we can be doing a much better job about at least explaining what the role of PHPM specialists are. What we've been seeing nowadays is a lot of physician colleagues directing a lot of important advocacy for their patients and for their communities at various different levels. But sometimes I think not having the foundational knowledge around some of the structures at play in terms of who's actually making the decisions and who employs whom and who has the leverage points to be able to make that policy right or make that funding right. And so I think we all have to think of, when we take off, and sometimes it's not possible to take off your professional affiliation, but putting on our citizenship hat, we all have a right to advocate on the issues that we think are important. But when we do that, we have to think about what is the role of a PHPM specialist, and am I actually directing my issue to the right person, or is it better placed at a politician, or is it better placed at this other organization, institution that has been influencing this issue in another way? I think that is why the training can improve in terms of how do we understand the role of PHPM specialists, but also to take a step back away from that, to train our physicians, to train our med students to better understand the systems and the structures that they work in, also means they'll be able to better advocate for their patients in front of them that struggle with the determinants of health, that struggle with the causes of the causes. So because when you know who to go to direct that advocacy, to direct that issue that you know the patient that's coming in front of you is presenting with disease and illness in a certain way, and they actually need stable housing, they need a basic income, who is the right person to approach for that? I think you'll be better, situated to not get burnt out. I remember a paper that was shared by a medical student in the States. It's called "To Fight Burnout, You Organize," and it's like so true, I think, in medicine, and so true in probably many fields. When you're faced with ongoing inequity and injustice, sometimes through lived experience, sometimes through the people that you care for and you look after, and not being able to do anything about it is almost worse than not knowing about it, right? And so how do you actually use that knowledge and leverage your privilege through allyship and through advocacy to be able to, and sometimes activism, to be able to do that work? So I recognize I kind of went a bit on a tangent when it comes to public health education for medical learners, but I think that is what we have to instill in our medical learners, and probably just people in general, is how do we collectively think about healthier communities, and that the responsibility lies on each one of us to be able to fight for that, for something that's bigger than ourselves.
When you highlighted the causes of the causes, for us as public health professionals, and like much of our public health training was, that was kind of like the core tenet, was emphasizing over and over, you're not just looking at why A caused B, but you gotta peel back the curtain and look under the layers. And I think that's really, getting deep and understanding what the specific needs of the population are in order to be able to work with them to come to a solution together. I think that's really a really powerful notion that hopefully through this pandemic and through the lessons we learned through this pandemic, that more policy and decision makers are able to kind of recognize as well.
You've just heard part 1 of Will, Linda, and Ben's conversation with Yipeng, a resident physician in public health and preventative medicine, about this unique specialty in medicine for its appreciation of both clinical and public health practice. Join us in the next episode and listen to the second half of the discussion, where they talk more about global health, public health, and public policy. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our content and would like to stay up to date, follow us on Instagram, Facebook, Twitter, and LinkedIn. To learn more about our community initiatives and how you can support us, visit our website at thepublichealthinsight.com. Join the PHI community, and let's make public health viral.